successful, and then you're going to implant that stimulator. So factors that influence therapy success. All of us want to be successful. So indications, as I explained, pain etiology, as I did talk to you guys, distribution, because as I said, you have areas that you're not going to have a target goes, so how are you going to cover the area? And also patient factors. How is coming patient factors? Patient has to really want to have the therapy done. A lot of times we see patients coming in to discuss stimulator because the partner or the mother wants them to be out of the meds and they heard about this. So it usually doesn't work. Patient has to be involved. Patient also has to be clear about what they're going to go for. They have to understand the process. They have to understand what all the steps they're going to go through. And they have to have very realistic expectations. Some patients come to you and they don't understand. They think this is a magical thing. They're going to put in there and all the pain's going to go away. So that patient never going to be successful because what they're looking for doesn't exist. So it's very important to explain and give the patient real expectations. And that's why the psychology comes in handy. Number one, the patient are more open to the psychology and really tell all their fears, all their questioning, and we really can target what the issues are and direct the questions and our answers towards the patient doubts. So this is related to the device, so we really have to get sufficient coverage. And you guys see me in the OR working with you. Sometimes the rep says, oh, we're fine. I'm not happy with a kind of borderline coverage because I know the rep is going to have to work much harder and the patient has to be pushing to get the coverage that they want. So this is your time at the OR to maximize your coverage. So let's see, if you put the stimulator at T9 and T10, you're going to reach the foot. But it's not going to be as good as if you're in that area. So if the rep that is doing your programming has to be pushing, patient's going to feel a lot more in the thigh, a lot more in that areas. It's going to be uncomfortable. So you don't want that. So you want to really take a little more extra time and make sure your coverage is the best you can really obtain in the OR. And that's going to dictate your coverage. So a lot of times people in the hardy, okay, that's the foot and let's go. And then later on, you're going to spend hours and hours trying to program it. So it's like those kind of things that save you time there, and they're going to create a lot of issues later on. So take your time there to get your best coverage. And that is going to really make you much better chance of targeting the electrical field and sustainability of your therapy. How you evaluated those clinical factors? Okay, so as I just told you guys, patient motivation, patient education, you really have to very good or successful psych evaluation, and patient has to fail other level therapies. Or patient didn't fail other level therapies, but they don't want to go to many medications or anything like that. So you have to have a very good directed patient. I do have patients who never had opioids in their life. They really said, I can't take this. I took once or twice. I don't feel well. I want something else available for me. And they have the right to do so. But that patient is absolutely motivated. That's what they want. So that patient is going to work. Other patients that they are very scared of needles, very scared to have something in their body, if they have not tried medications, they're not going to do well because they're going to be thinking about it. Maybe if I take one OxyContin that my cousin takes, I'll be doing well. So, you know what I'm saying? So you're going to do your trial, but they probably is not going to have the same successful, and probably you're going to have to do it again. I have a perfect example of a patient who did it very well. We just implanted her. She's a nurse. She came to me. She had a pump. She has multiple sclerosis. And the day one I saw her in the office, I knew she was going to be an excellent candidate for a dorsal column stimulator. But in her mind, she had a pump already. She wanted to work up with that pump. She wanted to make that pump work. So I tried everything that I could to make the pump work so she could work her steps to understand that my evaluation was corrected and the pump was not the best medication for her. But first of all, I wasn't sure. I had my feelings and my opinion as a physician, but we never can be sure in pain management because patient responds differently. But, you know, I knew she was going to do great in dorsal column stimulator, but she didn't know that. And once the patient doesn't believe it, it's not going to work. So finally, after I do the steps that I had to do, she did it very well, and she's very happy with the dorsal column stimulator and was successful and has been implanted. So how we do this? As you guys know, we do a temporary trial when we're going to put the patient into the room, and we put an external, percutaneously, you put a lead, and connect into external power source. We're going to evaluate those things. You want to make sure. So that's what you guys do when the patient comes in after trial. That's the phone call you're going to make to the patient. And that's when the patient comes for post-op. That's what I want you to know. How is your pain relieved? Oh, my pain is much better. What can you do? What is different in your life after you have this on? Oh, I'm working much more. Or I have a patient who said, Dr. Do Ouro, for the first time I could put heels on. You know, for that patient, it was something very significant. So I could put, for the past 5 years of my life, I only had to wear flats. Now I could wear heels and I didn't feel pain. So you're not going to ask that, but the patient usually tell you, and it's something that made significance to their lives. Coverage, you're going to know. Because some patients said, well, I have no pain relief. And you say, oh, it didn't work. No, you have to ask, did they coverage? Do you feel the stimulation at the areas where you have pain? Because the problem could be just the coverage. The lead can be had moved. Or the patient coverage not good. So we need to adjust that. Power requirements, as I told you guys. So the patient said, well, it worked, but they have to use a lot. They're looking for the foot, but they were using the foot. They have to do a lot on the thighs. You have to do that because that can tell you, yeah, maybe the patient doing fine, but when you're doing an implant, you might adjust your position of a lead. Maybe you can get in a better place when your power requirement is not that much. Also, decide what generator gonna implant it. If the patient had a lot of power requirements, probably you need a rechargeable battery, because this patient with a non-rechargeable battery in few years is going to be dead. So you need to decide your implantation here. Programming needs. So as again, I told you. So the patient programming using the 2 bottom electrodes, you need to reposition your trial and working on in a better way so you can have more coverage and more safety about, because you're not going to work with the 2 last electrodes. You move a little bit, you lose the coverage. So those are the kind of things you look by asking to the rep and see what are you using. And sometimes you guys don't see me asking that, but by the time I'm in the room, I already have those information. So I already know what I'm going to do. This is old. You usually don't have, you just use IPGs today, so we don't use radio frequency anymore. The RFs here that we talk about it. Okay, so, okay, that's what we have here. We have the leads, that's the ones they're going to implant. That's how it looks kind of in the spinal cord. I have other pictures to show. When you do the trial, that's how we connect. And we put in here, and the patient's going to have this, and their hands is able to say plus and minus, so up and down, on and off. This is the battery, and this is another battery that we implanted connecting to the leads. This is going to go into the buttocks or the abdominal area. This is the control that the patient is going to have after to turn it on and off, up and down remotely. And this is the recharging system when the patient is going to put this in the back and with a belt and charge when they're sitting down and doing some other activities. Okay, more electrodes, more coverage. You can see here. Now we have most of the leads has 8 electrodes at the tip, and we used to work with 4. I still old enough to be using the 4s, and the 8 came in. It helped us tremendously because most of the time that's what we need. We need a field of this. You guys see there. They use usually 3, 4 electrodes, negative, plus, and plus, negative. But this gives us some kind of safety because if the lead moves, what I tell you guys at Dr. Do Ouro, it doesn't, just joking, but if it doesn't move, you have this sense of safety. Not only that, sometimes they use different programs. So I see a patient has back and leg pain. So I cover better back with the top leads, and I do a program with them, and I cover the legs better with the lower leads. And so we can have a better programming for the patient and better pain control. In the past, we just have those leads to work.